Welcome back to Fundamentals of Chest Radiography. Today we are going to talk about lung cancer and metastases. Here are some numbers from the American Cancer Society. In 2020, there will be over 200,000 new cases of lung cancer in the United States alone. Half of those will be males and the other half will be females. It has been estimated that in 2020, more people will die of lung cancer than of prostate, colorectal, and breast cancer combined. It has been known for decades that cigarette smoking is by far the most important risk factor for lung cancer. Lung cancer accounts for more deaths than any other cancer in both sexes. In recent years, there is a slow but steady decrease in incidence rates and death rates, but it's quite a slow process. Symptoms include weight loss, cough, sputum streaked with blood, dyspnea, chest pain, voice change, etc. If diagnosed early, the 5-year survival rate for lung cancer is about 57%, which is okay. However, if you look at all stages, the 5-year survival rate is less than 20%. Now, you could ask, how could radiology help in screening for lung cancer? Which modality should we choose? This question has been asked in many trials in recent years, the first of which was the National Lung Cancer Screening Trial in the United States. In that trial, they recruited over 50,000 heavy smokers. By heavy smoker, they meant that a person who smokes 1 pack of cigarette per day for at least 30 years. They divided these people up into 2 groups. The first group received a baseline low-dose chest CT, and then another one at the first year, and then another one at the second year. And the second group received the baseline chest x-ray, and then another one at first year and another one at second year. Then they followed these people up, and according to their results, 20% lower lung cancer specific mortality rate was seen on the CT arm compared to the chest x-ray arm. So that means that with CT, they were able to diagnose small cancers, small lung cancers, which had better treatment options, and so the patients had a better chances of survival. That 20% might sound quite good to you, but you should know that quitting smoking leads to about 40% of lung cancer specific mortality rate reduction. That's why today, when people are offered low-dose lung cancer screening, they are also told that they should stop smoking at the same time. Just a couple words on the technique. So here are 2 images of the same patient. It's the same level of their chest. And you can see here that this is a diagnostic, so a full dose chest CT image where you can see the fissure quite nicely and the vessels are quite sharp. And here is the cancer, the ground glass opacity. And if you do the same level with low dose CT, you might not be able to visualize the fissures or as many vessels, but the cancer, in this case this ground glass opacity, is just as obvious as on the diagnostic or full dose CT. So this is proof that a low dose chest CT is just as good in diagnosing small tumors than a full dose CT. However, for the patient, it does matter whether he receives a full dose or only half or 1/3 of the full dose, as in the case of low dose CT. So after several of these cancer screening trials in the United States, in Canada, and some other countries, low dose chest CT screening is now offered free of charge for the risk group. In Europe, it is also recommended, but it is not free, unfortunately. In Hungary, where the most people get and the most people die of lung cancer, it's also not available free of charge, even though every hospital who has a CT is theoretically capable of performing these types of scans. And just a number here that in Hungary, out of 100,000 people, about 51 will die due to lung cancer. And if you only look at males, this number is actually around 70. Now, due to these lung cancer screening trials, we now have enough data so that the TNM of lung cancer was changed, because even though we suspected before these trials that a smaller cancer has a better survival rate, we now have proof that that is actually scientifically true and it can be proven to be true. So in the 8th edition of lung cancer staging, the T1 is now divided up into A, B, and C based on the size of the tumor. A T1A is a tumor less than 1 centimeter, B is a tumor which is less than, and a C is a lung cancer which is less than 3 centimeters in greatest diameter. And the T2 is now divided up into A and B, which relates to a tumor which is less than 4 centimeters, and the B is a tumor which is less than 5 centimeter in greatest diameter. Another result of these trials was that we now have evidence to show that the majority of primary lung cancers reside in the upper lobes. About 45% reside in the right upper lobe, 20% in the left upper lobe. So together that's 65%. This data comes out of the Nelson trial, which was the Dutch-Belgian trial in Europe. And so if you see a nodule in the upper lobe of a heavy smoking elderly men, for example, then that nodule is quite suspicious of being a primary cancer. But this is a chest X-ray course, and we should look at images of how lung cancer appears on the chest X-ray. Now, as a rule of thumb, you should remember that if you see a lung cancer on the chest X-ray, that's probably an advanced cancer. Here is an advanced peripheral tumor, for example. So there's a big nodule or a mass in the middle third of the right lung. It has smooth borders, and in the vicinity, in the right hilum, you can see this added soft tissue opacity and some more in the right peritracheal region. So these are probably pathological lymph nodes, and these peripheral tumors are usually adenocarcinomas. Central masses are usually the squamous cell carcinomas, and they can be easy to miss, especially when they are small and they do not cause any atelectasis. However, if they are larger, then they can be seen, because then the symmetricity of the hila will be lost. So here you can see this large mass. It's quite bulky and uneven. And so here is the primary cancer, which is probably causing some form of atelectasis, either subsegmental or segmental, and that is proven here by this coronal CT. So this is probably a squamous cell carcinoma sitting in the right hilum. Now, when a central tumor causes atelectasis of the complete right upper lobe, then you will see the famous golden S sign or reversed S sign. And so let's observe this. So there is a mass in the right hilum, and you can see the edge of the mass over here. And you can also see this homogeneous opacity in the right upper third of the right lung, and you can see this line which is convex towards the apex or convex the trachea. This would be the horizontal fissure separating the upper lobe from the middle lobe. However, due to the fact that there is volume loss, atelectasis, this line is no longer horizontal, it is convex towards the apex, and you can see that here. Now, if you continue this line and add the border of the mass, you will get this reversed S shape or the golden S sign. And this is a classic sign of a mass sitting in the right hilum and causing right upper lobe atelectasis. Pancoast tumors are unfortunately quite frequent. They tend to occur to males who are elder and who have worked all their lives, and they present to their GPs with some form of arm pain or shoulder pain. Now, if these patients are lucky, then they will receive a chest x-ray quite early on, and then the diagnosis will be known early, and as you can see it here, a Pancoast tumor is an apical tumor which usually causes rib destruction or Horner syndrome clinically, but it carries quite a low survival rate. So the 5-year survival rate is about 30%. And if patients are unlucky and they do not even get a chest x-ray, then they usually end up dying without a diagnosis, because a Pancoast tumor usually kills very early, even after the diagnosis is made. Now let's talk about metastases. Due to the fact that the lungs have a rich blood supply, virtually any primary cancer can metastasize into the lungs. Since the basal segments have the best vasculature, they have the best blood supply, then metastatic foci usually develop in the basal segments. But as you can see on this image, these foci can grow in any segment of the lung, and they appear to be randomly distributed. Some of them are nodules, some of them are masses. When you see these big round metastasis, then this is called cannonball metastasis, and it usually comes from renal cell carcinoma or cholangiocarcinoma. Metastasis is not only or cannot only be hematogenous, it can be lymphatic as well, as you can see it here. Now, on this image, in the lower third of the left lung, you can see added lines or reticular pattern, as we have mentioned before. And this might resemble to you cardiac edema. However, in cardiac edema, we saw peribronchial cuffing around the bronchi. We saw thicker curly A lines from the hilum to the periphery. We saw perpendicular curly B lines. We saw the meniscus sign indicating pleural effusion, and we saw cardiomegaly. None of which we see over here. We just see very thin lines, but they tend to be all over this lower third lung. And this was actually a case of a gastric cancer, and you can imagine that as the cancer cells start spreading through the lymphatics, they reach the basal segments of the left lung, and that's why you see these fine lines which all point to lymphangitic carcinomatosis. Bone metastasis. Just as a reminder, it's very important to look at the bones and the soft tissues and to compare both sides. Otherwise, you are going to miss these lesions. Bone metastases can be blastic, lytic, or mixed. And as you can see here, only, or for the most part, the anterior parts of the ribs are affected. The dorsal aspects are not so much affected. The clavicles are affected with these sclerotic lesions. The left humerus is normal appearing, and this was an elderly man who had a prostate cancer, and even though he had no pulmonary nodules, the bones show metastases. So this was my lung talk and my talk on lung metastasis. I hope you have learned a lot, and I will see you next time.